Yeah, thanks very much for presenting that interesting case. And we'll have the chance to talk a lot more about the treatment decisions as well. But first, I just wanted to get a feeling from everybody, just in a quick one sentence, about who drives decision making. How is the role of the surgeon and medical oncologist related to making decisions in early stage HER2 positive breast cancer? Tiffany, what do you do at your institution?
So we have a multidisciplinary approach and close communication between our surgeons and medical oncologists. And for a patient with a HER2 positive early stage breast cancer, tumor greater than 2 centimeters, or node positive disease, we are traditionally following a neoadjuvant approach. But the patients will meet with both the breast surgeon as well as breast medical oncologist right at the beginning of establishing that treatment plan.
And Adam, is it the same at
Yeah,
Pittsburgh?
we do almost exactly what Tiffany does. I think T2 and above or node positive will get neoadjuvant therapy. We'll see both the surgeon and the medical oncologist at the same time, or within a day or two of each other. We usually, again, will give neoadjuvant therapy. We actually have guidelines. We follow what's now called, I think, ClinPath guidelines. It used to be called VIA. And just about everybody who is T2 and above or node positive will get the neoadjuvant approach.
And I assume a similar at Dana-Farber, you have a tumor board. Do you include your surgeons in the tumor board also?
So we actually, like the rest of our colleagues on this panel, do have a multidisciplinary approach to actually all patients with invasive cancer. So they meet with a medical oncologist and a surgeon at the time of their initial presentation. In this case, as we'll discuss, clearly this is a patient who benefits from neoadjuvant approach, but there are other patients in whom the decision making is a little bit more complicated, and I think that's why it's really important to have both a surgeon and a med-onc together for that initial discussion. We also have a separate multidisciplinary tumor board for complex cases in which review of pathology in real time is helpful, but even for when we meet the patient for the first time, we try to have always a surgeon and a medical oncologist together.
That's interesting. I mean, that's a great approach that you're able to do that. We usually will see the patients. We all work in the same clinic, but we do see them at different times just so that the workup is done. But we all sit in the same room, so it helps a lot, and worked a lot of neoadjuvant therapy.